Sometimes I think that the search for a medicine that's actually going to help those of us with secondary progressive MS, kind of like a cross between a horse race and a soap opera. But it may be finally time for one of the BTK inhibitors to cross the finish line. But then again, not so fast. Well, hello, and welcome to another episode of You and Me and Multiple Sclerosis. My name is Pam. I've been living with multiple sclerosis for almost 40 years. And like you, I've been following all of the research that's been coming out lately about a variety of medications that might actually do some good for us. Just late last week, the ECTRIMS conference was held, very well attended, and a lot of new research that's being reported on. And among the things that's been coming out is the latest news on a BTK inhibitor called Tolebrutinib. And I'd like to share a few things with you today. I'm trying to get this out really quickly because I know that you're starting to see things in the news. So I'm going to pull together what I know. There's going to be more coming, I'm sure, but I'm not going to wait for it all to come out. I'm just going to get out what I already know so that you know what I know. But let's go ahead. We'll start with the article. Well, here's a piece of exciting news that came out of the ECTRIMS conference in Copenhagen, Denmark. And the article is published September 20th, 2024, so hot on the heels of the conference itself. It's called Novel Agent First to Slow Disability in Non-Relapsing Secondary MS. And as the article says, a new investigational drug has become the first agent to slow disability in patients with non-relapsing secondary progressive multiple sclerosis. The Phase 3 Hercules trial showed Tolebrutinib, an oral Bruton's tyrosine kinase or BTK inhibitor, delayed the time to onset of 6-month confirmed disability progression by 31% compared with placebo. In addition, Tolebrutinib almost doubled the number of patients who experienced confirmed disability improvement from 5% to 10%. However, they say, these benefits come with the potential safety issue of liver toxicity, with raised liver enzymes reported in 4% of patients and very severe liver enzyme rises occurring in 0.5% of patients, one of whom died after undergoing a liver transplant. And I would like to know more about that. Any fatality from a medicine is a fatality too many. But I hope they will tell us whether or not this person already was suffering with any kind of liver problem or some other comorbidity that created this complication. The results were presented today by Robert Fox, MD, Vice Chair of Research at the Cleveland Clinic's Neurological Institute, Ohio, at the Congress of the European Committee for Treatment and Research in Multiple Sclerosis, or ECTRIMS, 2024. We have finally found a therapy that can alter the compartmentalized inflammation that is driving progressive MS, he said. Fox pointed out that the population enrolled in the Hercules trial had stopped having clinical relapses. These are the patients for whom current immunomodulator therapies don't really work at all. They don't slow disability. This trial suggests that Tolebrutinib can fill that void, and now we have something to offer this patient group, he said. He estimated that up to 30% of MS patients at his clinic may fall into this category. And it's quite likely that some of my audience falls into that category as well, as I believe I do. A typical patient with non-relapsing SPMS who was included in this trial may have experienced a gradual decline in the distance they can walk or the ease with which they could climb stairs, he explained to Medscape Medical News. I would project that this therapy will slow down that gradual decline and that in some patients it may actually stop the decline, he added. Fox said that BTK inhibitors are believed to have two main mechanisms of action relevant to MS: downregulating B cells, probably mostly in the periphery, and as these agents can cross the blood-brain barrier, they also appear to reduce the inflammatory activity of microglia and macrophages in the brain. He noted that the disability progression in non-relapsing secondary progressive multiple sclerosis patients is thought to be caused by compartmentalized inflammation in the brain, which is what tolebrutinib may be targeting. He noted that siponimod has also shown benefit in secondary progressive MS in the EXPAND trial, but the benefit was almost entirely restricted to patients who had experienced recent relapses. Ocrelizumab has been shown to be beneficial in a trial in primary progressive MS, but again, a large proportion of patients in that study had active focal inflammation at baseline. Then they go ahead talking about the trial results. The Hercules trial included 1,131 patients with non-relapsing secondary progressive MS, defined as having an expanded disability status scale between 3.0 and 6.5, no clinical relapses in the previous 24 months, and documented evidence of disability accumulation in the previous 12 months. They were randomly assigned 2-to-1 to receive 60 milligrams of tolebrutinib as an oral daily dose or placebo for up to approximately 48 months. This was an event-driven trial with 288 6-month confirmed disability progression events required. About 23% of patients in each group discontinued treatment, and 12% to 17% who had confirmed disability progression elected to cross over to open-label tolebrutinib. The study population had an average of 49 years, had a median EDSS score of 6, and a mean time since last clinical relapse of over 7 years. So this was a really very quiescent patient population in terms of focal inflammation, Fox noted. Results showed that the primary endpoint showed a 31% reduction in the risk of 6-month confirmed disability progression, 26.9% tolebrutinib versus 37.2% placebo. Hazard ratio 0.69, 95% confidence interval 0.55 to 0.88. Rates of 3-month confirmed disability progression were 32.6% in the tolebrutinib group versus 41.5% with placebo, a 24% risk reduction. In addition, 6-month confirmed disability improvement was achieved by 10% of tolebrutinib patients versus 5% in the placebo group. And then they say that there is a head-scratcher finding. Surprisingly, he noted, tolebrutinib did not appear to slow brain atrophy. Despite seeing a benefit on disability progression, we saw no significant slowing of brain atrophy or brain volume loss over the course of this study, Fox reported. He described this discordance between disability rates and brain volume loss rates as a bit of a head-scratcher. In terms of safety, the main concern is liver enzyme elevations, which occurred at greater than 3 times the upper limit of normal in 4.1% of the tolebrutinib group versus 1.6% in the placebo group. A small, or 0.5% proportion of patients treated with tolebrutinib experienced very severe elevations, greater than 20 times upper limit of normal, in liver enzymes, and one of these patients had to have a liver transplant and died due to post-operative complications. A reminder that this can be a very serious complication of this drug, said Fox. However, he noted that all the very severe liver enzyme rises occurred in the first 3 months, and it is now recommended that patients undergo weekly liver enzyme monitoring for the first 12 weeks of treatment. Well, that's very sensible. As long as the effects are reversible, that would be a very sensible thing to do. Other adverse effects that were increased slightly in Tolebrutinib group were upper respiratory infections and possibly hypertension. Weekly liver enzyme testing. Fox cautioned that patients starting Tolebrutinib would need to undergo weekly liver enzyme testing in the first few months of treatment. They would need to be very attentive to this monitoring, but if they are willing to do that, then I think many of these patients will be very eager to take this drug that may slow down their disability progression. The drug's manufacturer, Sanofi, said that the trial results will form the basis for applications to global regulatory authorities, with submissions starting later this year. And since this year is almost over, I assume that means they're going to do that post-haste. Commenting on the trial for Medscape Medical News, Ludwig Kappos, MD, professor of neurology at University Hospital and University of Basel, Switzerland, said, "The trial was important as it had shown a robust effect on confirmed disability progression in a population of secondary progressive MS with no or very low signs of focal inflammation. The effect is similar and probably more pronounced than that seen in the Siponimod trial, also in advanced secondary progressive MS," he added. Kappos believes more work will be needed to make sure the liver toxicity can be prevented. But if that can be resolved, then patients could have a significant delay in accumulating disability. The Gemini trials also slowed disability, they say. 2 other phase 3 trials of Tolebrutinib were presented during the same ECTRIMS session, Gemini 1 and 2, which compared the new drug to teriflunomide, a standard of care treatment in participants with relapsing MS. Neither study met the primary endpoint of an improvement in annualized relapse rates compared with teriflunomide. However, with respect to the key secondary endpoint, in a pooled analysis of data from Gemini 1 and 2, Tolebrutinib delayed the time to onset of 6-month confirmed disability worsening by 29%, a finding in line with the main results of the Hercules trial. The significant impact of Tolebrutinib on disability accumulation versus teriflunomide in the absence of a statistically superior impact on relapses also suggests that Tolebrutinib may address smoldering neuroinflammation, which manifests as progression independent of relapses, Fox said. The Hercules trial was sponsored by Sanofi, which is a very big pharmaceutical company, as most of us know. Fox is a paid advisor to Sanofi, and Kappos led the EXPAND trial of Siponimod in secondary progressive MS. And now, as I like to do, I always like to try to find an interview with the lead investigator so that it puts a human face on the medications that we're hearing about. And here's an interview with Dr. Robert J. Fox. And they start out with a top takeaways list, which is helpful for us, so I'll read this to you. Over 20 therapies exist for relapsing MS, but none have best shown to effectively slow the progression secondary progressive MS until recently. The Hercules trial introduced a therapy that significantly reduced disability progression in patients with non-relapsing secondary progressive MS. And finally, the Gemini trials support these findings by demonstrating a reduction in sustained disability progression despite no change in relapse rates.
Up to this point, we have over 20 approved therapies that help relapsing MS, meaning they reduce relapses and relapsing forms of MS. But at this point, we don't have any therapies that effectively slow the little by little progression we see in secondary progressive MS. So what's exciting to me about these results from the Hercules trial is that we finally have identified a therapy that slows progression of disability in a population of patients without relapses, so the non-relapsing secondary progressive MS population. These results are really important to me as a practicing neurologist because every day I see patients with secondary progressive MS for whom I have no treatments. They have gradual, little by little decline in their walking function, in their arm function, in their cognitive function, and I really have no therapies to offer to them at this point. And this looks to have promise to be an effective therapy. I think the biggest takeaway is that we have finally identified a therapy that slows the insidious progression of secondary progressive MS, that little by little decline in function for which up to this point we've had no effective treatments. So finally we have hope to slow this form of the disease. The Gemini trials gave confirmation of what we saw in Hercules, in that although there was no reduction in the annualized relapse rate in the patients treated with Tolebrutinib versus teriflunomide, we did see a slowing of the disability progression. We saw a reduction in the proportion of patients with sustained progression of disability. And although that was a negative trial from the relapsing aspect, it was positive in slowing disability progression, and I think points to and confirms what we found in the Hercules trial of secondary progressive MS.
And then also I think it's worth hearing from Sanofi, the company that's actually investing in making Tolebrutinib and hoping to get it released into clinical practice. So here is an interview with Dr. Eric Wallstrom from Sanofi. Well, once again, they're nice enough to give us the top takeaways, so let's read these together. Non-relapsing secondary progressive MS remains difficult to treat due to its complex pathology, including prior damage, aging, and smoldering inflammation beyond focal lesions. Tolebrutinib, a BTK inhibitor, holds promise for non-relapsing SPMS by effectively targeting central nervous system inflammation with its superior brain penetration. And I think we've seen this in another video, that small particles penetrate the brain much more effectively than the larger molecules that are used in other therapies. So that's kind of exciting. And then the third one is that the diversity in pharmacological profiles of BTK inhibitors, such as covalent versus non-covalent binding, underscores the potential uniqueness of Tolebrutinib's mechanism of action in treating MS, in treating secondary progressive MS.
You talked about it there for a little bit of a second. We really don't have many, or if that, any approved therapeutics for non-relapsing secondary progressive MS. So talk a little bit more about this patient population, why it's been so difficult to treat, and why we really haven't seen such therapeutic success thus far.
No, that's a great question. I mean, it's not for a lack of trying, I would say. I mean, there are compounds that have been tested. I think the two studies I think about when I think about progressive MS and sort of successful studies, siponimod study in SPMS, we have the ocrelizumab study in primary progressive MS. That's kind of the benchmarks, if you will. And of course, the siponimod didn't result in a label for non-relapsing SPMS. And I think it kind of tells us something about what we think is going on. Because if we think simplify, I mean, we have to simplify, in life, because MS is a very complicated disease with lots of different aspects. But if we simplify, I think we can think about three things going on in non-relapsing SPMS and SPMS in general. One thing is there is still some of what we think is the relapsing pathology, the focal lesions, likely peripherally driven mainly, not in the brain itself, perhaps. So focal lesions, relapses. Not so much in non-relapsing SPMS. That's what makes it hard to treat. That's a small part of the pathology. Then there is some aging as well and prior damage. Probably also very difficult to treat. We'll have to decode how we treat aging and how we make the brain more plastic. But it's prior damage, aging. But then there is a third part, and there is some inflammation going on. One popular term now is smoldering MS. It's kind of an umbrella term. And a lot of different things going on. The normal appearing white matter. There is meningeal infiltrate, at least in some patients. There is there is the slowly expanding lesions. But it's very, very clear, I think, to everybody looking at MS, that there is more going on than the focal lesions and the T2 and gadolinium lesions. There is additional pathology. And that's the interesting part. We have good treatment for the relapsing part, and the aging part is hard to tackle. We have to come in early. We have to sort of prevent damage in the brain. But there is this other part, the middle part, where we think that it is possible to make inroads, and that's where we think we can make progress.
Let's talk a little bit about Tolebrutinib, obviously a BTK inhibitor. So why do we believe that this mechanism of action can be successful in this population specifically? Talk a little bit about just the mechanism of action and why Tolebrutinib is a little bit different than maybe some other investigational agents out there right now.
Exactly. Yeah. No, that's a very important question. And actually what we said already before seeing these results is that in some compound classes, the compounds are more similar, Of course, there may be some small differences, but maybe if you look at CD20 antibodies, for instance, I have worked with them before, they're relatively similar, I would say. Not identical, but relatively similar. If you look at the small molecules like BTK inhibitors, and the BTK inhibitors in particular are significantly different in terms of the pharmacology. They have different levels of brain penetration. They have different levels of potency. They even have different mode of action. Some are covalent binders, some are non-covalent binder. They have different reaction speeds. So we have done a bit of work around that. We have done some studies where we actually put some of the front-runner compounds in class, evobrutinib, tolebrutinib, fenebrutinib, side by side, and done comparison. It's now published. It's work by a couple of Sanofi colleagues, including Tim Turner. So that's published and people can see. And that shows that there are differences. There are differences in terms of when you combine potency and brain and brain penetration. So we think that tolebrutinib compares favorably in terms of being able to effectively target BTK in the CNS based on the combination of potency and brain penetration.
And then I will play a little bit of a clip from the ECTRIMS Patient Community Day recordings. I did put the link out to this before for you all to go look at. I don't know if you got a chance to watch it. I did, and I actually recorded it. But I am not going to post that because they say that they are going to make that available, and I will certainly post the link when it's up. It's not up yet, but I don't want to get a copyright violation or anything. So I'm not going to play a lot, but I will play part of it.
And finally, for those people that have progression without inflammation, and this is where there is more debate in which are the drugs that can help or cannot help. We just heard this morning about a positive phase 3 result with one drug that is small. So when I say small, that means that it can cross the CNS and go into the central nervous system. And although it's been just a flash, what we have seen, the first primary outcome, who was delay in progression, was met. Okay, so compared to placebo, this drug seems to decrease by 30% the progression of disability. Of course, this is a phase 3 trial, which is already a good number of patients incorporated. There are things that we don't understand in these first results, because, for example, this was not translated into, for example, a decrease in the global atrophy of the brain, which is something that we are usually coupling one thing with the other. And the other thing is that this drug doesn't seem to have an anti-inflammatory effect. Okay, so it seems to have an effect in progression, but not directly in the acute inflammatory process. So there are these two components. We need to further see the results, because of course this has been like seeing for 6 minutes the slides, and there's a lot to read, and we don't have the paper, etc. But this is, I think, a promising achievement. This is what we were aiming, to look for drugs that could have a role in this progression without relapses, because this is where we are have more difficulties in changing the natural history.
And then last but certainly not least, we need to get a little bit of a dose of reality from Dr. Gavin Giovannoni. And again, this is a clip from his most recent MS selfie, and I will link the whole thing below. It's certainly worth listening to. As usual, he lets us know that there might be something even better in the pipeline that we might want to be holding out hope for. So once again, the horse race continues.
I must point out that the dark horse is a drug called remibrutinib that's currently being studied in relapsing remitting MS, and we have no detailed PK and PD data, pharmacokinetic and pharmacodynamic data on its CNS effects. But if it does have potent CNS effects, then it may be as effective as tolebrutinib and fenebrutinib. And the news on the Ectron's grapevine is that remibrutinib appears not to have a clear liver toxicity signal. So if that's the case, then it may be the winner in terms of the BTK battle, in terms of its use in clinical practice. Almost certain neurologists would go for the safer compound rather than the compound that was more likely to cause liver toxicity. So we'll have to wait for all the results to come in, but it's a very interesting time that we have the first positive results of a second generation BTK inhibitor, Tolebrutinib, and in the wings we've got two other BTK inhibitors in trial with potentially very interesting results to come.
Okay, well, I've thrown a lot at you, and I hope that it was helpful. I hope that you found it informative and interesting. And as I said, I will be following along with some of this stuff, and if there's more of interest that comes out, I will certainly make another video and post it for you. But this will give you some idea of what we're dealing with. Tolebrutinib certainly sounds good. It's targeted specifically at non-active secondary progressive MS, which is a population that has been too long underserved and ignored. So that is all to the good. But I will say, this liver toxicity thing, I don't know. In a way, it's kind of like when they first came out with Tysabri and almost immediately realized that there was a danger from PML, which is that brain disease that's irreversible and fatal. And they pulled it off the market for a while, and then they had to retrench. And then they came up with the test for the JC virus that once you knew whether you had that or not, you knew whether it was safe to take Tysabri. And the same thing I think is happening with Tolebrutinib. They saw that there was liver toxicity in an alarmingly large number of patients, and so they retrenched. And now they realize they have to proceed with caution and do more monitoring and testing. So it doesn't really mean that something is no good. It just means we have to take precautions. And I'm really glad. One thing that you can see with the clinical trial process being what it is, it takes a long time. But the reason it takes a long time is because they want the medicines not just to be effective, but to be safe. And I appreciate that, because I'm no scientist. I have to trust at some level that they know what they're doing. And when I see how they go through these clinical trials and the caution with which they proceed, I do feel more trusting than I otherwise would. But that's all I have for you today. So until my next video, you really do need to take good care of yourself so that we stay healthy and we can take advantage of these new medicines when they become available. I'll see you again in my next video.